Vital signs. The measurement and recording of the vital signs is the first step in the process of physically examining a patient, that is, in collecting objective data about a patient's signs like what the nurse can observe, feel, hear or measure. This is a fundamental skill for nurses working in all clinical areas, but one which only develops with practice. This lecture introduces the knowledge and skills required by nurses to accurately measure and record a patient's vital signs, that is, their blood pressure, pulse or heart rate, temperature, respiratory rate, pain level and blood oxygen saturation. By the end of this lecture, we would like you to 1. Describe the procedures used to assess the vital signs. 2. State the factors that can influence each vital signs. 3. Identify equipment routinely used to assess vital signs. 4. Identify the normal ranges for each vital signs. 5. Explain the rationales for using different routes and sites for assessing the vital signs. And 6. Explain how vital signs should be interpreted and used in nursing practice. Vital signs, body temperature, pulse, respirations, and blood pressure, indicate the function of some of the body's homeostatic mechanisms. Recently, many agencies have designated pain as a fifth vital signs. Pulse oximetry is also commonly measured on the same time as the traditional vital signs. Measurement and interpretation of the vital signs are important components of assessment that can yield information about underlying health status. Client teaching concerning the vital signs is a key aspect of health promotion. Typical or normal ranges of values for vital signs have been established for clients of various age groups as shown in the table below. During initial measurement of a client's vital signs, the values are compared with these normal ranges to determine any variation that might indicate illness. When several sets of vital signs have been obtained, this information forms a baseline for comparison of subsequent measurements. Isolated vital sign values are less helpful. A series of values should be taken and evaluated to establish trends for the client. Vital sign trends that deviate from normal are much more significant than isolated abnormal values. The frequency with which to assess vital signs should be individualized for each client. Healthy people may have vital signs checked only during annual physical examinations. Clients seen in ambulatory settings, wellness clinics, or psychiatric institutions may require infrequent vital sign checks. Most inpatient settings have a policy regarding the frequency of vital sign assessment, minimally every 8 hours for stable clients. Physicians order additional vital sign checks at specific intervals based on the client's condition, like post-operatively or after an invasive diagnostic procedure. The nurse caring for the client may decide to monitor vital signs more frequently if the client's condition changes. When and how often to assess a specific client's vital signs are chiefly nursing judgments, depending on the client's health status. Some agencies have policies about taking clients' vital signs, and physicians may specifically order a vital sign monitoring like vital signs every 1 hour. Body temperature. Body temperature reflects the balance between the heat produced and the heat lost from the body, measured in heat units called degrees. There are two kinds of body temperature: core temperature and surface temperature. Humans are warm-blooded creatures, which means they maintain a consistent internal body temperature independent of the outside environment. The body's surface or skin temperature can vary widely with environmental conditions and physical activity. Despite these fluctuations, the temperature inside the body, the core temperature, remains relatively constant, unless the client develops a febrile illness. The body's cells, tissues, and organs require this constant internal temperature and function optimally within a relatively narrow temperature range. Regulation of body temperature. Body temperature regulation requires the coordination of many body systems. For the core temperature to remain steady, heat production must equal heat loss. The hypothalamus, located in the pituitary gland in the brain, is the body's built-in thermostat. It can sense small changes in body temperature and stimulates the necessary responses in the nervous system, circulatory system, skin, and sweat glands to maintain homeostasis or the state of dynamic equilibrium. Heat production. The body continually produces heat as a byproduct of chemical reactions that occur in body cells. This collective process is known as metabolism. The process of thermoregulation keeps core temperature fairly constant regardless of where the heat is being produced. The basal metabolic rate, BMR, is the amount of energy the body uses, and thus the amount of heat produced, during absolute rest in an awake state. Physical exercise, increased production of thyroid hormones, and stimulation of the sympathetic nervous system can increase heat production. Heat loss. Just as the body is continually producing heat, it is also continuously losing heat. Heat is lost through four processes: radiation, conduction, convection, and evaporation. Exposure to a cold environment increases radiant heat loss. All objects with temperatures above absolute zero constantly lose heat through infrared heat rays. Covering the body with closely woven, dark fabric can reduce radiant heat loss. Conduction is the transfer of heat from one object to another. The body loses a considerable amount of heat to the air through conduction. It can also lose heat to water during swimming or tepid baths. Convection is the loss of heat through air currents such as from a breeze or a fan. Evaporation causes heat loss as water is transformed to a gas. Examples of evaporation include diaphoresis or sweating during strenuous exercise or when one is febrile. Factors affecting body temperature. Understanding the factors that can affect body temperature can help nurses accurately assess the significance of body temperature variations. Age. Newborns have unstable body temperatures because their thermoregulatory mechanisms are immature. It is not uncommon for elderly persons to have body temperatures less than 36.4 degrees Celsius, 97.6 degrees Fahrenheit, because normal temperature drops as a person ages. Remember this fact when evaluating low-grade temperatures in the elderly or identifying those at risk for hypothermia. Environment. Ordinarily, changes in environmental temperatures do not affect core body temperature, but core body temperature can be altered by exposure to hot or cold extremes. The degree of change relates to the temperature, humidity, and length of exposure. The body's thermoregulatory mechanisms are also influential. For example, infants and older adults often have diminished control mechanisms. Death may occur if a person's core body temperature drops to 25 degrees Celsius, 77 degrees Fahrenheit, or rises to 45 degrees Celsius, 113 degrees Fahrenheit. Time of day. Body temperature normally fluctuates throughout the day. Temperature is usually lowest around 3 a.m. and highest between 5 and 7 p.m. A person's body temperature can vary by as much as 2 degrees Celsius, 3.6 degrees Fahrenheit, from early morning to late afternoon. Theorists attribute this variation to changes in muscle activity and digestive processes, which are usually lowest in the early morning during sleep. Even greater variation in body temperature at various times of the day is found in infants and children. Although researchers have established no absolute relationship between circadian rhythm and body temperature, 95% of clients have their maximum temperature elevation around 6 p.m. A study by Baudry suggests once-a-day fever screening of afebrile clients at 6 p.m. This would ease burdens on staff time and limit the disruption of sleeping clients during the night. Exercise. Body temperature increases with exercise because exercise increases the breakdown of carbohydrates and fats to provide energy. Strenuous exercise, such as running a marathon, can temporarily raise the temperature to as high as 40 degrees Celsius, 104 degrees Fahrenheit. Stress. Emotional or physical stress can elevate body temperature. When stress stimulates the sympathetic nervous system, circulating levels of epinephrine and norepinephrine increase. As a result, the metabolic rate increases, which, in turn, increases heat production. Stressed or anxious clients may have an elevated temperature with no underlying pathology. Hormones. Women usually have greater variations in their temperature than do men. Progesterone, a female hormone secreted at ovulation, increases body temperature 0.3 degrees to 0.6 degrees Celsius, 0.5 degrees to 1 degree Fahrenheit, above baseline. By measuring their temperature daily, women can determine when they ovulate, which is the basis for the rhythm method of birth control. After menopause, mean temperature norms are the same for men and women. Thyroxine, epinephrine, and norepinephrine also elevate body temperature by increasing heat production. Alterations in body temperature. Normal body temperature when measured orally usually ranges between 36.5 degrees and 37.5 degrees Celsius, 97.6 degrees and 99.6 degrees Fahrenheit. This state of normal body temperature in a client is termed afebrile. There are two primary alterations in body temperature, pyrexia and hypothermia. Pyrexia. A body temperature above the usual range is called pyrexia, hyperthermia, or in layman's term, fever. A very high fever, such as 41 degrees Celsius, is called hyperpyrexia. Four common types of fever are intermittent, remittent, relapsing, and constant. During intermittent fever, the body temperature alternates at regular intervals between periods of fever and periods of normal or subnormal temperatures. During remittent fever, a wide range of temperature fluctuations, more than 2 degrees Celsius, occurs over the 24-hour period, all of which are above normal. In relapsing fever, short febrile periods of a few days are interspersed with periods of 1 or 2 days of normal temperature. During a constant fever, the body temperature fluctuates minimally but always remains above normal. A temperature that rises to fever level rapidly following a normal temperature and returns to normal within a few hours is called fever spike. The clinical signs of fever vary with the onset, course and abatement stages as shown in this slide. These signs occur as a result of changes in the set point of the temperature control mechanism regulated by the hypothalamus. Nursing interventions for a client who has fever are designed to support the body's normal physiologic processes, provide comfort, and prevent complications. During the course of fever, the nurse needs to monitor the client's vital signs closely. Nursing measures during the chill phase are designed to help the client decrease heat loss. At this time, the body's physiologic processes are attempting to raise the core temperature to the new set point temperature. During the flush or crisis phase, the body processes are attempting to lower the core temperature to the reduced or normal set temperature. At this time, the nurse takes measures to increase heat loss and decrease heat production. Nursing interventions for a client with fever are shown in this slide. Hypothermia. Hypothermia is a core body temperature below the lower limit of normal. The three physiologic mechanisms of hyperthermia are 1. Excessive heat loss, 2. Inadequate heat production to counteract heat loss, and 3. Impaired hypothalamic thermoregulation. The clinical signs of hypothermia are listed in this slide. Managing hypothermia involves removing the client from the cold and rewarming the client's body. For client with mild hypothermia, the body is rewarmed by applying blankets. For severe hypothermia, a hypothermia blanket, an electronically controlled blanket that provides a specific temperature, is applied, and warm intravenous fluids are given. Wet clothing should be replaced by dry clothing. Nursing interventions for clients who have hypothermia are also listed in this slide. Purposes of assessing body temperature are the following. 1. To establish baseline data for subsequent evaluation. 2. To identify whether the core temperature is within normal range. 3. To determine changes in core temperature in response to specific therapies such as antipyretic medication, immunosuppressive therapy, or invasive procedure. 4. To monitor clients at risk for imbalanced body temperature, like clients at risk for infection, those who have been exposed to temperature extremes. Assess for 1. Clinical signs of fever or hypothermia. 2. Site most appropriate for measurement. 3. Factors that affect core body temperature. Temperature measurement establishes a baseline for comparison as a disease progresses or therapies are instituted. The reliability of a temperature value depends on selecting the most appropriate site, choosing the correct equipment, and using the correct procedure. Sites. Use judgment when selecting the route to measure temperature. The 5 sites used are the mouth, ear, rectum, forehead, temporal artery, and axilla. In most clinical situations, any of these sites is satisfactory if the nurse uses proper technique and accounts for normal variations for the different sites. Additional sites are the esophagus and pulmonary artery, both of which are considered core temperatures. Normal temperature varies within a person, among people, and among sites. Oral. The most common site for temperature measurement is the mouth. Advantages of the oral route include easy access and client comfort. Drinking hot or cold liquids can affect temperature measurement. Wait 15 to 30 minutes to allow the client's mouth temperature to return to baseline before placing the thermometer. Oral temperature assessment may not be prudent or safe for infants, young children, unconscious or irrational clients, or clients with seizure disorders. Rectal. Rectal temperature measurement, once thought to be the most accurate and commonly used clinically, has now been replaced by tympanic technology that is less invasive for the client. Clients often do not tolerate rectal temperatures well because of discomfort and embarrassment. If this route is used, take care to avoid placing the thermometer into fecal material, which may elevate the temperature reading falsely. The rectal route is contraindicated in clients with diarrhea, those who have undergone rectal surgery, those with rectal diseases, and those with cancer who are neutropenic. In selected clients, like quadriplegics, rectal temperature measurements may cause vagal stimulation, which can result in bradycardia and syncope. Ear. Since the development of the tympanic membrane thermometer, the ear has been added to the list of sites where temperature can be measured easily and safely. Measuring temperature at this site has many advantages. The tympanic membrane receives its blood supply from the same vasculature that supplies the hypothalamus, thus, tympanic temperature readings reflect core body temperature. Cerumen in the ear canal, crying, or otitis media will not alter temperature readings significantly. Smoking, drinking, and eating, which slightly alter oral temperature measurement, do not affect tympanic temperature measurement. The ear is readily accessible and permits rapid temperature readings in very young, confused, or unconscious clients. Because the ear canal harbors fewer pathogens than the oral or rectal cavities, infection control is a minor concern with the tympanic site. There is some concern that this site may be less accurate than rectal or oral temperature readings. Poor measurement technique is often responsible for errors in measurement, usually false low readings. To obtain an accurate reading, hold the pinna and gently pull the ear slightly upward and backward to straighten the ear canal. Pull pinna down and straight back for a child under 3 years old. Fit the probe snugly in the client's ear canal, and angle it toward the jawline. Temporal artery, forehead. Recently developed devices allow fast, safe measurement of temperature at the site of the temporal artery. The limited research available using these devices indicates they may be more accurate than tympanic thermometers, and comparable to oral thermometers in accuracy. They are easy to use and well tolerated by infants and young children. Measurements do not appear to be affected by perspiration and are consistent when taken on either the right or left side of the forehead. Axillary. The axillary route is considered the least accurate and least reliable site because several factors can influence the measurement obtained. For example, if the client has bathed recently, the reading may reflect the temperature of the water used. Friction used to dry the skin may influence the temperature. The axillary route is recommended for infants and children and is the route of choice in clients who cannot tolerate measurement by other routes. Equipment. Equipment used for temperature measurement includes thermometer, thermometer sheath or cover, water-soluble lubricant, disposable gloves, towel, and tissues wipes. Types of thermometers includes electronic thermometers, tympanic membrane thermometers, temporal artery thermometers, disposable paper thermometers, and temperature-sensitive strips. Once used commonly, glass mercury thermometers are no longer being used due to the dangers of exposure to mercury. 1. Electronic thermometers. Healthcare facilities use the electronic thermometer extensively. Many types are on the market, but all have similar characteristics. The thermometer consists of a battery-powered display unit and a temperature-sensitive probe connected to the display unit by a thin cord. A disposable plastic sheath covers the probe to prevent the transmission of infection. Electronic thermometers provide readings in less than 60 seconds. When used orally, they are most accurate if placed in the sublingual pocket. The thermometer displays results based on the Celsius or Fahrenheit scale. Some thermometers can display readings from both scales. The electronic thermometer is ideally suited for use with children because the sheath is unbreakable and the time necessary for accurate measurement is relatively short. A separate probe can be used for rectal temperature measurement. 2. Tympanic membrane thermometer. The tympanic membrane thermometer is a portable, handheld device resembling an otoscope that recharges using a battery pack. It records temperature through a sensor probe placed in the ear canal to detect infrared radiation from the eardrum. Some studies have revealed discrepancies between these readings and core body temperature, resulting in both false positive and false negative readings obtained using this device. These discrepancies can be minimized by using the same ear and device for measurement each time and by ensuring that the user is well trained. Because discrepancies are usually small, the convenience, safety, and efficiency of tympanic temperature measurement outweigh its disadvantages. The tympanic membrane thermometer is appropriate for infants older than 2 months or very young children who may have difficulty remaining still for extended periods. Because recordings are obtained within 2 seconds, the tympanic membrane thermometer often is preferred in emergency departments or other areas where assessments must be made quickly. Tympanic thermometers should not be used on people with ear drainage or scarred tympanic membranes. 3. Temporal artery thermometer. The temporal artery thermometer is a handheld device that scans the forehead and measures temperature over the temporal artery. The temporal artery thermometer corrects for radiant heat loss from the forehead by measuring the ambient temperature at the same time the skin temperature over the temporal artery is measured. The thermometer then adjusts the temperature measurement to discount radiant heat loss. Measurement of temperature over the temporal artery does not require contact with mucous membranes, but the head must be uncovered since bandages or clothing will trap heat. Also, moisture on the skin can affect the accuracy of measurement. 4. Disposable paper, chemical thermometers. Single-use paper thermometers are thin strips of chemically treated paper with raised dots that change color to reflect the temperature. Disposable thermometers are very convenient when infection control is a concern because they are discarded following a single use. These thermometers are available with readings in Celsius or Fahrenheit and are reported to be accurate. For oral temperature measurement, they are placed deeply in the sublingual pocket and left in place for 60 seconds. When used for axillary temperatures, the strips are placed vertically against the trunk of the body and held in place by the upper arm for 3 full minutes. 5. Temperature-sensitive strips. Temperature-sensitive strips can be used to obtain a general indication of body surface temperature. They are usually placed on the forehead or abdomen. The skin under the strip must be dry. After a specified length of time, the strip changes color. On one brand, a green N indicates a normal temperature, a brown N indicates a transition phase, and a blue-green F indicates an elevated temperature. The transition phase reflects the onset of a high temperature in the area where the strip was placed. The strip is removed and discarded after the color change has been noted. This method is particularly useful in the home. Because children younger than 2 years still have immature thermoregulatory systems, any variation from normal should be confirmed. 6. Glass mercury thermometer. Although some homes still have glass thermometers, healthcare environments no longer use these devices because of the risks of mercury exposure to people and the environment should the thermometer break. Mercury exposure can cause respiratory irritation, gastrointestinal irritation, and renal damage. Prolonged exposure causes neurological impairment. Instruct clients regarding the risk mercury exposure poses and the hazard of cleaning up mercury should the thermometer break. Instruct them to purchase new safe equipment. Mercury thermometers are no longer sold in retail stores. Implementation. Check that all equipment is functioning. If necessary, shake a glass thermometer down to below 35 degrees Celsius. That indicator fluid will not fall below the starting level if the client's temperature is less than that. Beginning with the thermometer on a very low temperature allows the nurse to note that the indicator fluid has risen to the client's actual temperature. Performance. First, explain to the client what you are going to do, why it is necessary, and how the client can cooperate. Discuss how the results will be used in planning further care or treatments. Then, wash hands and appropriate infection control procedure. Don gloves if performing a rectal temperature. Next, provide for client privacy. Then, place the client in appropriate position. For example, lateral or Sims position for inserting a rectal thermometer. Then, place the thermometer on the appropriate side. Apply a protective sheath or probe cover if needed. Lubricate a rectal thermometer. Wait the appropriate amount of time 2 to 3 minutes for an oral or rectal temperature using glass thermometer, 6 to 9 minutes for an axillary temperature with a glass thermometer. Electronic and tympanic thermometers will indicate that the reading is complete through a light or tone. Check package instructions for length of time to wait prior to reading chemical dot or tape thermometers. Then, remove the thermometer and discard the cover or wipe with a tissue if necessary. Next, read the temperature and record it on ULI worksheet. If the temperature is obviously too high, too low, or inconsistent with the client's condition, recheck it with a thermometer known to be functioning properly. Wash the thermometer if necessary and return it to the storage location. Last, document the temperature in the client record. A rectal temperature may be recorded with an R next to the value. An axillary temperature may be recorded with AX or marked on a graph sheet with an X. Insert the probe below the client's tongue and into the sublingual pocket of the mouth. Ask the client to close his or her lips around the probe. Hold the probe, supporting it in place. Rationale: inserting the probe into the sublingual pocket obtains the most accurate temperature. The weight of the probe will displace it from the sublingual pocket if left unsupported. Apply water-soluble lubricant liberally to thermometer probe tip. Rationale: lubricant facilitates insertion of thermometer without irritating or traumatizing the rectum. Separate client's buttocks with one gloved hand until the anal sphincter is visible. Rationale: visual exposure of anus ensures accurate placement of probe. Ask client to take a deep, slow breath. Insert thermometer into anus in direction of umbilicus, 1 inch for a child and 1.5 for an adult. Do not force. Rationale: deep, slow breath allows client to relax external sphincter. Insertion depth allows adequate exposure of probe to blood vessels in rectal wall. Hold the probe in place until machine emits a beep. Obtain reading. Rationale: holding thermometer prevents rectal damage or perforation caused by client moving with thermometer in place. Place thermometer against middle of axilla. Fold client's arm down and place across chest, enclosing thermometer in axillary area. Rationale: this position maintains correct position of thermometer against blood vessels in axilla. Insert probe into ear canal, making sure the probe fits snugly. Avoid forcing the probe too deeply into the ear. Pulling the pin back, up, and out in an adult will straighten the ear canal. Some manufacturers recommend moving the thermometer in a figure 8 pattern. Rotate the probe handle toward the jaw line. Rationale: straightening the ear canal permits better exposure of the tympanic membrane. Snug fit into the ear canal is also necessary for accurate temperature detection. Forceful deep insertion could result in injury to the eardrum. Angling the probe toward the jawline ensures an accurate reading. Pulse. Contraction of the ventricles of the heart ejects blood into the arteries. The force of the blood entering the aorta from the left ventricle causes stretching or distension of the elastic aortic wall. As the aorta first expands and then contracts, a pulse wave is created that travels along the blood vessels. The pulse wave or pulsation can be felt as a throb or tap where the arteries lie close to the skin surface. Compliance of the arteries is their ability to contract and expand. Cardiac output is the volume of blood pumped into the arteries by the heart and equals the result of the stroke volume times the heat rate per minute. For example, 65 milliliters times 70 beats per minute equals 4.55 L per minute. When an adult resting, the heart pumps about 5 liters of blood each minute. In a healthy person, the pulse reflects the heartbeat, that is, the pulse rate is the same as the rate of the ventricular contractions of the heart. A peripheral pulse is a pulse located away from the heart, for example, in the foot, wrist or neck. The apical pulse, in contrast, is a central pulse, that is, it is located at the apex of the heart. Factors affecting pulse rate. Understanding the factors that affect pulse rate helps with accurate assessment of the significance of pulse rate variations. Age. The average pulse rate of an infant ranges from 100 to 160 beats per minute. The heart rhythm in infants and children often varies markedly with respiration, increasing during inspiration and decreasing with expiration. The normal range of the pulse in an adult is 60 to 100 beats per minute. Autonomic nervous system. Stimulation of the parasympathetic nervous system dominant activation during resting states results in a decrease in the pulse rate. Normally, parasympathetic nervous system input slows the pulse rate below 100 beats per minute. Conversely, stimulation of the sympathetic nervous system results in an increased pulse rate. Sympathetic nervous system activation occurs in response to a variety of stimuli, including pain, anxiety, exercise, fever, ingestion of caffeinated beverages, and changes in intravascular volume. Medications. Certain cardiac medications, such as digoxin, decrease pulse rate. Medications that decrease intravascular volume, such as diuretics, may cause a reflex increase in pulse rate. Other medications mimic or block the effects of the autonomic nervous system. For example, atropine inhibits parasympathetic input, causing an increased pulse rate. Other medications, such as propranolol, block sympathetic nervous system action, resulting in a decreased heart rate. Sites. The pulse can be assessed in any location where an artery lies close to the skin surface and can be compressed against a firm underlying structure such as muscle or bone. The most commonly assessed pulses are the temporal, carotid, apical, brachial, radial, femoral, popliteal, pedal, and posterior tibial. Temporal. The temporal artery courses across the temporal bone of the skull. The pulsation of the temporal artery is most easily palpated just in front of the upper part of the ear. Carotid. The sternomastoid muscles, which stand out when the jaw is clenched forcefully, run from below the ear to the clavicle and sternum. Beneath the sternomastoid muscles lie the carotid arteries. The carotid artery is most easily palpated at the lower half of the neck, along the medial border of the sternomastoid muscle. Palpating the carotid artery in the upper part of the neck may result in stimulation of the carotid sinus, which causes a reflex drop in pulse rate. The carotid pulse best represents the quality of pulsation in the aorta because of its proximity to the central circulation. Apical. The contraction or beating of the heart ventricles also can be palpated with the hand or auscultated with a stethoscope placed over the area of the left ventricle. Normally, this area is at the level of the fifth intercostal space at about the midclavicular line. Brachial. The brachial artery lies between the groove of the biceps and triceps muscles in the inner aspect of the upper arm. The brachial pulse is palpated most easily with the client's arm extended at the elbow and supported by the examiner to prevent muscle contraction, which may obscure the pulse. Radial. The radial artery is the site most commonly assessed in the clinical setting. The radial pulse is palpated on the thumb side of the inner aspect of the wrist. Femoral. The femoral pulse is palpated in the anterior, medial aspect of the thigh, just below the inguinal ligament, about halfway between the anterior superior iliac spine and the symphysis pubis. Deep palpation may be required to detect the femoral pulse beneath the subcutaneous tissue. Popliteal. The popliteal pulse is palpable behind the knee in the lateral aspect of the popliteal fossa, the hollow area at the back of the knee joint. The pulse is best assessed with the knee flexed and the leg relaxed. The client may be supine or prone. Pedal. The pedal pulse or dorsalis pedis pulse can be felt on the dorsal aspect of the foot, the area of the foot that is on top in a standing position. The pulse is palpated lateral to the tendon that runs from the great toe toward the ankle. The dorsalis pedis pulse may be congenitally absent in some clients. Posterior tibial. The posterior tibial pulse is located behind the malleolus, the rounded protuberance of bone, of the inner ankle. The pulse is palpated by curving the fingertips over the bone. Assessing the pulse. Baseline pulse rate and rhythm are established during the initial nursing assessment and are used for comparison with future measurements. A stethoscope and a Doppler ultrasound device may be used to measure pulse rate. Stethoscope. Auscultation of the apical pulse requires a stethoscope. The stethoscope should have snugly fitting earpieces and thick-walled tubing about 12 inches, 30 centimeters, long for optimal sound transmission. The stethoscope should be equipped with a bell and a diaphragm. Doppler. Peripheral pulses that cannot be detected by palpation may be assessed with an ultrasonic Doppler device. A conductive gel is first applied to the skin to reduce resistance to sound transmission. The transmitter of the device is then placed over the artery to be assessed. High-frequency waves directed at the artery from the transmitter are disturbed by the pulsating flow of blood and are reflected back to the ultrasound device. The sound disturbances, Doppler shifts, are amplified and heard through earpieces or a speaker attached to the device. Doppler assessment of the pulse is generally used to determine the adequacy of blood flow to an area for which occlusive vascular disease threatens the blood supply or for postoperative assessment where peripheral circulation can be occluded. The Doppler also may be useful when obesity or edema obscures the pulse, or in situations of cardiopulmonary collapse where peripheral vasoconstriction makes pulses difficult to palpate. Methods. Palpation and auscultation are methods used to assess pulse rate. Palpation. The pulse is palpated using the first and second or second and third fingers of one hand. Use light pressure initially to locate the area of strongest pulsation. More forceful palpation may be applied to count the rate, determine the rhythm, and assess the quality of pulsation. Count the number of pulses for 30 or 60 seconds and multiply as necessary to yield pulses per minute. The time interval used to assess the pulse depends on the client's condition and the agency's norms. Clients with irregular or abnormally slow or fast pulse rates are best assessed for 1 full minute. Clients with regular rhythms and normal rates may be assessed for a shorter time. Intervals of 15 seconds may be used for clients with regular rhythms when reassessing the pulse frequently, as during recovery from anesthesia. Regardless of the time interval selected, count the initial pulsation as 0. Do not count pulses at or after completion of the time interval. Counting the first pulse as 1 or counting pulses after the period of assessment results in overestimation of the pulse. The error is multiplied when intervals of less than 60 seconds are used to assess the rate. Counting even one extra pulsation in a 15-second pulse assessment results in overestimation of the pulse rate by 4. Auscultation. Auscultation of the apical pulse provides the most accurate assessment of the pulse rate and is the preferred site when the peripheral pulses are difficult to assess or the pulse rhythm is irregular. Assess the apical pulse by placing the diaphragm of the stethoscope over the apex of the heart, which is located at the 5th intercostal space at the midclavicular line. The sounds heard are due to vibrations caused by the opening and closing of the cardiac valves. Each heartbeat consists of 2 sounds. The first, S1, is caused by closure of the mitral and tricuspid valves that separate the atria from the ventricles. The second sound, S2, is caused by the closure of the pulmonic and aortic valves. The sounds are often described as a muffled lub-dub. Together, they constitute one heartbeat. To determine the apical pulse, count the heartbeats for 1 full minute. Assessing pulse characteristics. Assess the pulse for rate, rhythm, and quality. Pulse rate and rhythm are routinely assessed. Pulse quality is assessed less often or in exceptional circumstances when abnormalities may be anticipated. Any pulse out of the range of normal, rate or rhythm, is considered dysrhythmic. Cardiac rate. In adults, the normal rate is 60 to 100 pulsations per minute. Adult pulse rates above 100 beats per minute are called tachycardia. Sympathetic nervous system activation may result in tachycardic rates. Tachycardic rates also may occur when the impulse for cardiac contraction comes from an abnormal site in the heart that stimulates the heart to beat faster. An abnormally slow pulse rate is called bradycardia. In adults, a pulse rate below 60 beats per minute is considered bradycardic. Bradycardia may be the normal resting heart rate in a trained athlete. Disease of the SA node may result in bradycardia because of poor impulse formation. In addition, enhanced parasympathetic nervous system activity, example, stimulation of the carotid sinus, may cause bradycardia. Cardiac rhythm. Normally, cardiac contractions occur at evenly spaced intervals, resulting in a regular rhythm. Infants and children often have increased pulse rates during inspiration and decreased rates during expiration. Heart disease, medications, or electrolyte imbalances may alter the heart's normal rhythmic beating, causing an irregular pulse. An irregular pulse rhythm that still displays a consistent pattern is called regularly irregular. An example is Pulsus bigeminus, in which a normal heartbeat initiated in the SA node is followed by a heartbeat initiated in a different part of the heart. The second beat is early and often weaker than the first, resulting in a regularly irregular pulse. If the pulse has no pattern, it is called irregularly irregular. Irregular pulses may be a component of many conditions, including atrial fibrillation. In atrial fibrillation, the atria do not contract in a synchronous fashion, and the primary impulse for the heartbeat does not come from the SA node. Consequently, the time interval between successive ventricular contractions varies, and an irregular pulse is detected. When you note an abnormal pulse rhythm, consider using the auscultatory method to obtain an apical pulse rate. Also, determine if irregularity of the pulse is a new finding for the client. Pulse volume, also called the pulse strength or amplitude, refers to the force of blood with each beat. Usually the pulse volume is the same with each beat. It can range from absent to bounding. A normal pulse can be felt with moderate pressure of the fingers and can be obliterated with greater pressure. A forceful or full blood volume that is obliterated only with difficulty is called full or bounding pulse. A pulse that is readily obliterated with pressure from fingers is referred to as weak, feeble, or thready. The elasticity of the arterial wall reflects its expansibility or its deformities. A healthy, normal artery feels straight, smooth, soft and pliable. Older people often have inelastic arteries that feels twisted and irregular upon palpation. When assessing a peripheral pulse to determine the adequacy of blood flow to a particular area of the body, the nurse should also assess the corresponding pulse on the other side of the body. The second assessment gives the nurse data with which to compare the pulses. For example, when assessing the blood flow to the right foot, the nurse assesses the right dorsalis pedis pulse and then the left dorsalis pedis pulse. If the client's right and left are the same, the client's dorsalis pedis pulses are bilaterally equal. Assessing peripheral pulse. Purposes for assessing the peripheral pulses are: 1. To establish baseline data for subsequent evaluation. 2. To identify whether the pulse is within normal range. 3. To determine whether the pulse rhythm is regular. 4. To compare the equality of peripheral pulses on each side of the body. 5. To monitor and assess changes in clients' health status. 6. To monitor clients at risk for pulse alterations like those with a history of heart disease or experiencing cardiac arrhythmias, hemorrhage, acute pain, fever. Assess for the following. 1. Clinical signs of cardiovascular alterations, other than pulse rate, rhythm or volume, like dyspnea, fatigue, pallor, cyanosis, palpitations, syncope. 2. Factors that may alter pulse rate, like emotional status or activity level. And 3. Site most appropriate for assessment. Assessing the peripheral pulse. First, wash hands, identify the client, and explain the procedure. Rationale: provides safety and increases client compliance. Then, position client comfortably with forearm across chest or at side with wrist extended. Rationale: relaxed position of lower arm with wrist extended allows easier artery palpation. Next, place fingertips of your first 2 or 3 fingers along the groove at base of thumb, on client's wrist. Rationale: fingertips are the most sensitive part of the hand for palpating pulses. Do not use the thumb to palpate, it has a strong pulse that you may confuse with the client's. Then, press against radial artery to obliterate pulse, then gradually release pressure until you feel pulsations. Assess for regularity and strength. Rationale: moderate pressure is needed to accurately assess the pulse's rate and regularity. Then, if pulse is regular, count pulse for 30 seconds and multiply by 2. If pulse is irregular, count for 1 full minute. If irregular pulse is a new finding, assess apical radial rate. Count the initial pulse as 0. Rationale: prevents overestimation of pulse. If pulse is irregular, a longer counting period ensures a more accurate pulse rate determination. An apical radial rate is helpful to determine if irregular beats are strong enough to perfuse to peripheral pulse sites. Rationale: prevents overestimation of pulse. If pulse is irregular, a longer counting period ensures a more accurate pulse rate determination. An apical radial rate is helpful to determine if irregular beats are strong enough to perfuse to peripheral pulse sites. Next, record the pulse in beats per minute on your worksheet. Last, document the pulse rate, rhythm, and volume and your actions in the client record. Also note variation in pulse rate and any abnormal skin. Assessing the apical pulse. Purposes: 1. To obtain the heart rate of newborns, infant, and children, or of an adult with irregular rhythm. 2. To establish baseline data for subsequent evaluation. 3. To determine whether the cardiac rate is within normal range and the rhythm is regular. 4. To monitor clients with cardiac disease and those receiving medications to improve heart action. When checking for apical pulse, assess the following. 1. Clinical signs of cardiovascular alterations, other than pulse rate, rhythm, volume like dyspnea, fatigue, pallor, cyanosis or syncope. And 2. Factors that may alter pulse rate like emotional status, activity level, medications that affect heart rate. Assessing the apical pulse. First, wash hands, identify the client, and explain the procedure. Rationale: provides safety and increases client compliance. Then, position client in supine or sitting position with sternum and left chest exposed. Rationale: this position allows easy access for selection of auscultatory site. Rustling from clothing or bed linens will not distract nurse from hearing pulse. Next, use an alcohol swab to clean the stethoscope and earpieces before using. Rationale: maintains asepsis. Then, warm diaphragm of stethoscope by holding it in the palm of your hand for 5 to 10 seconds. Rationale: a cold metal or plastic diaphragm can startle the client when placed directly on the chest. This could alter pulse rate. Next, locate apex of the client's heart by palpating the space between the 5th and 6th rib, 5th intercostal space, and moving to the left midclavicular line. Then, insert the earpieces of stethoscope into your ears and place diaphragm over apex of client's heart. Rationale: the heartbeat is usually heard loudest at the 5th intercostal space, near the midclavicular line. Next, assess the heartbeat for regularity and dysrhythmias. Rationale: frequent irregularities within 1 minute may indicate inadequate cardiac perfusion. If rhythm is regular, count the heartbeat for 30 seconds, and multiply by 2. Count for 1 full minute if the rhythm is irregular. Count the initial pulse as 0. Rationale: prevents overestimation of pulse. Heart rate is more accurate when counted over a longer period if the rate is irregular. Then, replace the client's gown and assist the client to return to a comfortable position. Rationale: provides for client comfort. Last, document the pulse site, rate, rhythm, and volume and your actions in the client record. Respiration is a term used to summarize two different but related processes, external respiration and internal respiration. External respiration is the process of taking oxygen into and eliminating carbon dioxide from the body. Internal respiration refers to the use of oxygen, the production of carbon dioxide, and the exchange of these gases between the cells and the blood. There are basically two types of breathing, costal or thoracic breathing and diaphragmatic or abdominal breathing. Costal breathing involves the external intercostal muscles and other accessory muscles. It can be observed by the movement of the chest upward and outward. By contrast, diaphragmatic breathing involves the contraction and relaxation of the diaphragm, and it is observed by the movement of the abdomen, which occurs as a result of the diaphragm's contraction and downward movement. The process of inspiration is active. Inspiratory muscles contract, resulting in increased intrathoracic volume as the lungs expand. The pressure in the airway becomes negative and air flows inward. At the end of inspiration, natural lung recoil occurs, the airway pressure becomes slightly positive, and the air flows out as the muscles relax. Expiration is basically a passive process. Normal breathing is automatic and involuntary. At rest, the normal adult respiratory rate is 12 to 20 breaths per minute. Normal tidal volume, the amount of air moving in and out with each breath, is 500 milliliters or 6 to 8 L-min. In people with healthy respiratory systems, the normal stimulus to breathe is hypercarbia, an increased carbon dioxide level. Chemoreceptors throughout the body sense changes in carbon dioxide levels and stimulate the respiratory center, which increases or decreases respiratory rate and depth accordingly. Assess respirations during every vital sign evaluation. Establish a set of normal baseline measurements of rate, rhythm, depth, and quality for each client so comparisons can be made. The respiratory assessment can provide valuable information and insight into a client's condition. When assessing a client's respiratory status, keep in mind the client's normal pattern, the influence of any disease conditions, and the influence of any therapies that could affect the client's respiratory status. Rate. Respiratory rate changes with age. At rest, the normal respiratory rate for an infant is 30 to 60 breaths per minute, decreasing to 12 to 20 breaths per minute for an adult. Tachypnea is an abnormally fast respiratory rate, usually above 20 breaths per minute in the adult. Bradypnea is an abnormally slow respiratory rate, usually less than 12 breaths per minute in the adult. Apnea, the absence of respirations, is often described by the length of time in which no respirations occur, like a 10-second period of apnea. Continuous apnea is synonymous with respiratory arrest and is not compatible with life. Rhythm and depth. Eupnea refers to normal respiratory rhythm and depth. Regularity refers to the pattern of inspiration and expiration. Expiration is normally twice as long as inspiration. Assess depth by observing the movement of the chest wall. Also note the use of accessory muscles. The table describes abnormal patterns, such as Biot's respirations, Cheyne-Stokes respirations, Kussmaul respirations, and apneustic respirations. Quality. Respirations are usually automatic, quiet, and effortless. When assessing respirations, be attentive to changes from the normal quality. Abnormalities in quality are usually characterized by effort or noise. Dyspnea describes respirations that require excessive effort. Respirations can be painful and labored. Clients may report being unable to catch their breath. Dyspnea can occur at rest or with activity. Dyspnea that occurs with activity is called exertional dyspnea. Healthy people who are not in good physical condition may experience exertional dyspnea. Breathing also can be noisy. A number of terms are used to describe the different types of noisy respirations that can be heard without a stethoscope. Stridor is a harsh inspiratory sound that may be compared to crowing. It may indicate an upper airway obstruction. It is commonly heard in children with croup or after aspiration of a foreign object. Wheezing is a high-pitched musical sound. It is usually heard on expiration but may be heard on inspiration. It is associated with partial obstruction of the bronchi or bronchioles, as in asthma. Sighs are breaths of deep inspiration and prolonged expiration. Everyone sighs, and sighing aids in the expansion of alveoli. However, frequent sighing may indicate stress or tension. Purposes for assessing respirations. 1. To acquire baseline data against which future measurements can be compared. 2. To monitor abnormal respirations and respiratory pattern and identify changes. 3. To assess respirations before administration of medications such as morphine. 4. To monitor respirations following administration of anesthesia. 5. To monitor clients at risk for respiratory alterations like those with fever, pain, anxiety. Perform the respiratory assessment without clients being aware that you are doing so. If clients are conscious of the procedure, they may alter their breathing patterns or rate. Assess the respiratory rate after or before taking the radial pulse, while holding the client's wrist. If respirations are very shallow and difficult to visually detect, count them while observing the sternal notch, where respiration is more apparent. If the client is sleeping, rest a hand gently on the client's chest to detect its rise and fall. With an infant or young child, assess respirations before taking the temperature so the child is not crying, which alters the respiratory status. Assessing respirations. 1. Wash hands and identify client. Rationale: provides for client safety. 2. After or before assessment of pulse, keep your fingers resting on client's wrist and observe or feel the rising and falling of chest with respiration. If client is asleep, you may gently place your hand on the client's chest so you can feel chest movement. You may not explain procedure to client. Rationale: explaining procedure may make client self-conscious about respirations and could cause him or her to alter respiratory pattern. 3. When you have observed one complete cycle of inspiration and expiration, and if respiration is regular, look at second hand of watch and count the number of complete cycles in 30 seconds and multiply by 2. In children younger than 2 years or in adults with an irregular rate, count for 1 full minute. Rationale: children normally have irregular respiratory patterns. Ensures accuracy of assessment. 4. If respirations are shallow and difficult to count, observe at the sternal notch. Rationale: respirations are more visible at the sternal notch. 5. Note depth and rhythm of respiratory cycle. Rationale: respiratory characteristics give additional data about alterations in respiratory status. 6. Discuss findings with client and document respiratory rate, depth, rhythm, and character. Rationale: maintains legal record and communicates with healthcare team. Blood pressure is the force that blood exerts against the walls of the blood vessels. The pressure in the systemic arteries is most commonly measured in the clinical setting. Blood pressure is stated in millimeters of mercury, mmHg. Physiologic factors determining blood pressure. The contractions of the heart result in a pulsating flow of blood into the arteries. The pressure is highest when the ventricles of the heart contract and eject blood into the aorta and pulmonary arteries. The blood pressure measured during ventricular contraction, or cardiac systole, is the systolic blood pressure. During ventricular relaxation, or cardiac diastole, blood pressure is due to elastic recoil of the vessels, and the measured pressure is the diastolic blood pressure. The mathematical difference between the measured systolic and diastolic blood pressures is the pulse pressure. For instance, a systolic pressure of 120 mmHg and a diastolic pressure of 80 mmHg result in a pulse pressure of 40 mmHg. Blood flow. Blood flow is essentially equal to cardiac output. Cardiac output is the product of stroke volume, the amount of blood each ventricle pumps with each heartbeat, and heart rate. A stroke volume of 70 milliliters and a heart rate of 72 beats per minute result in a cardiac output of 5040 milliliters per minute, or about 5 liters per minute. Average cardiac output in a resting man is 5.5 liters per minute. Poor cardiac pumping, as occurs with a failing heart, or reduced blood volume, as in severe hemorrhage, may reduce stroke volume, which in turn decreases cardiac output. Bradycardia also may cause decreased cardiac output. Conversely, a rapid heart rate and larger stroke volumes would be expected to increase cardiac output. The magnitude of output change created by increases or decreases in one factor, either heart rate or stroke volume, is influenced by the other factor's concurrent response. An increase in heart rate in response to a decrease in stroke volume to maintain a normal cardiac output is an example of a compensatory response. Resistance. Friction among the cells and other blood components and between the blood and the vessel walls causes blood flow resistance. The friction within the blood components reflects the blood's viscosity and is largely due to the number and shape of the blood cells. Normally, the number and type of blood constituents do not vary greatly, and viscosity is a constant factor. Friction between the blood and the vessel walls varies with the dimensions of the vessel lumen. Contraction and relaxation of the smooth muscle in the vessel walls control the diameter of the blood vessel. The autonomic nervous system regulates this vascular tone. Constricted vessels offer greater resistance, thus increasing blood pressure. Dilated vessels offer less resistance, thus decreasing blood pressure. Factors affecting blood pressure. Major factors affecting blood pressure include age, autonomic nervous system, circulating volume, medications, and normal fluctuations. Age. Blood pressure gradually increases throughout childhood and correlates with height, weight, and age. These normal changes make it difficult to identify abnormal blood pressure levels for children at various developmental stages. The National Institutes of Health states that children and adolescents with blood pressure levels of 120/80 mmHg or above, but less than the 95th percentile, are considered to have prehypertension. Blood pressure consistently above the 95th percentile for age indicates a need for diagnostic evaluation. In adults, systolic and diastolic blood pressure increase gradually as age advances. In part, this trend is due to increased systemic vascular resistance, reflecting arterial narrowing and decreased vessel elasticity due to atherosclerotic vessel disease. The increase in systolic blood pressure is proportionally greater than the increase in diastolic blood pressure, therefore, pulse pressure widens. Autonomic nervous system loss. Measured blood pressure may be quite low, although sympathetic nervous system activity is increased markedly. Circulating volume. A decrease in circulating volume, either from blood or fluid loss, results in lower blood pressure. Fluid volume deficit can occur with abnormal, unreplaced losses such as diarrhea or diaphoresis. Insufficient oral intake also can cause fluid volume deficit. Excess fluid, such as in congestive heart failure or renal failure, can cause elevated blood pressure readings. Medications. Any medication that alters one or more of the previously described determining factors may cause a change in blood pressure. Examples are diuretics, which decrease blood volume, cardiac medications, which affect the heart's rate or contractile force, narcotic analgesics, which reduce pain and sympathetic nervous system activity, and specific antihypertensive agents. Normal fluctuations. Blood pressure fluctuates from minute to minute in response to a variety of stimuli. Increased ambient temperature causes blood vessels near the skin surface to dilate, decreasing resistance and blood pressure. Blood pressure also fluctuates with the respiratory cycle, increasing during expiration and decreasing during inspiration. In addition to these fluctuations, there is a discernible circadian pattern to blood pressure. Investigators have documented a consistent variation in blood pressure throughout the day. Abnormalities. Hypertension and hypotension are the abnormalities of blood pressure. Hypertension. Hypertension is the condition in which blood pressure is chronically elevated. Although in industrialized societies there is a trend toward increased blood pressure with advancing age, hypertension is a dangerous disease associated with an increased risk of morbidity and mortality due to cardiovascular complications, such as stroke or heart failure. Therefore, chronically elevated blood pressure is treated aggressively in adults of any age. For adults of any age, blood pressure between 120/80 and 139/89 mm Hg is considered prehypertension. Adults with blood pressure above 140/90 mm Hg should be evaluated for hypertension. Hypertension is diagnosed on the basis of serial elevated values, rather than a single measurement. Studies have shown that some clients demonstrate higher recorded blood pressure in the physician's office than in the home setting. This is referred to as the white coat effect. Ambulatory blood pressure measurements refer to blood pressure values obtained away from the clinical setting while the person is engaged in normal activity. Ambulatory blood pressure measurements are helpful in diagnosing hypertension accurately and in planning treatment. Hypotension. Hypotension is blood pressure below 100/60 mm Hg. Low blood pressure readings can be normal for some healthy, young adults and are no cause for concern. A sudden drop in blood pressure, significantly below the normal range for a person, causes hypotension. For example, a hypertensive client who usually has blood pressure readings of 180/94 mm Hg would be considered hypotensive if his or her blood pressure fell to 120/80 mm Hg. Once again, a significant change from baseline values is more important than any one specific measurement. Equipment. There are several different pieces of equipment that can be used to measure blood pressure: the sphygmomanometer, stethoscope, Doppler ultrasound, and electronic devices. Sphygmomanometer. A sphygmomanometer consists of an inflatable bladder enclosed in a non-distensible cuff. The bladder is connected to an inflating mechanism such as a bulb or pump, a valve for deflation, and a manometer. The manometer may be an aneroid or gravity mercury type. The gravity mercury type has always been standard, but it is now being phased out in many healthcare settings because of environmental concerns. Aneroid manometers have a circular gauge marked in 2 mm increments. The pressure transmitted from the cuff causes movement of a metal bellows within the manometer, a movement indicated by a needle on the gauge. Aneroid manometers require yearly calibration with a properly functioning mercury manometer or other pressure standard. These routine checks of manometer function should be made throughout the range of pressure measurement to ensure the device's accuracy. Aneroid manometers with a stock peg at the 0 point or an external reset are not recommended because verifying the accuracy of the manometer is impossible. Mercury manometers consist of a vertical glass tube marked in 2 mm increments. Cuff pressures are transmitted through the tubing into the manometer and force the mercury to rise in the glass tube. The surface tension of the mercury in the tube causes the top of the mercury column to be curved. The pressure reading is made from the top point of the curved surface, the meniscus, of the mercury. The manometer must be at eye level to ensure an accurate reading. Particulate matter or air, bubbles in the glass tube distort readings. Enough mercury must be present in the reservoir to maintain the meniscus at 0 with the cuff deflated. The air vent at the top of the glass tube must be clean and allow free passage of air, or the mercury will be unable to rise and fall smoothly in the tube. The tubing and hand bulb in all sphygmomanometers must be free of cracks or holes, and connections must be airtight to prevent leaks that cause poor transmission of pressure and consequently inaccurate readings. To allow the operator to control the rate of deflation, the deflation valve must function smoothly. Assessing blood pressure. Blood pressure may be measured directly with a catheter placed into an artery. Direct measurement provides a continuous reading of blood pressure and is used in critical care settings. However, blood pressure is usually measured by indirect methods, using an inflatable cuff to temporarily occlude arterial blood flow through one of the limbs. As the cuff is deflated and flow returns, the blood pressure is determined by palpation, auscultation, or oscillations. Sites. Blood pressure can be measured in either the upper or lower extremity. Upper extremity. The blood pressure usually is measured in the arm. Wrap a cuff around the upper part of the limb and auscultate or palpate blood flow at the brachial artery. Blood pressure also may be determined by auscultation or palpation of the radial artery in the wrist with an appropriately sized cuff applied to the forearm. Blood pressure readings will differ when measured in the upper and lower arm, so it is important to note the site of blood pressure measurement. Avoid measuring blood pressure in any arm with a venous access device, especially an internal arteriovenous fistula, peripheral vascular access for hemodialysis, or a peripherally inserted central catheter (PICC) line. Also, if the client has had a mastectomy, blood pressure monitoring on the same side can further impede circulation, contributing to lymphedema. Lower extremity. The blood pressure would be measured in the lower extremity if the client had arteries in the upper extremity that could not be palpated, if the upper extremity was covered by dressings or splints, if the client had a PICC line, or if the client had a mastectomy. Wrap the cuff around the thigh or above the ankle. Thigh pressure measurement requires a larger, appropriately sized cuff. Place the client in a flat, supine position with the cuff centered mid-thigh over the popliteal artery. Auscultate or palpate blood flow at the popliteal fossa. When an appropriately sized cuff is used, Blood pressure measurements should vary only slightly from readings measured in the upper extremity, unless the client has peripheral vascular disease. Using a cuff that is too small will result in falsely high readings. To measure blood pressure in the ankle, place the client in a flat, supine position, and place a standard arm cuff just above the malleolus. Auscultate or palpate the posterior tibialis or dorsalis pedis pulse as you deflate the cuff. For accurate data interpretation, note the site of blood pressure measurement. When determining the blood pressure by the auscultatory method, use an inflatable cuff to temporarily occlude blood flow through a limb. As you deflate the cuff and blood flow returns, the Korotkov sounds can be heard with a stethoscope placed over the artery. 5 distinct phases are identifiable, as shown in image on this slide. The onset of phase I Korotkov sounds is the recorded systolic pressure. Diastolic pressure is indicated by the onset of phase V sounds in adults and phase IV sounds in children. Because the Korotkov sounds are low in frequency, the bell of the stethoscope is best used for auscultation, although most practitioners use the diaphragm because of its larger shape and ease of placement. If the sounds are inaudible with the diaphragm, try the stethoscope bell. Do not press the head of the stethoscope too firmly against the skin because doing so may partially occlude blood flow and alter the reading. An auscultatory gap is the absence of Korotkov sounds between phases I and II. Failure to identify an auscultatory gap may result in underestimation of the systolic blood pressure or overestimation of the diastolic pressure. Find the auscultatory gap by palpating the brachial or radial pulse while inflating the cuff. Inflate the cuff about 30 mm Hg above the number where palpable pulsation disappears. In addition to detecting an auscultatory gap, palpation gives an initial estimate of systolic blood pressure and eliminates the need to inflate the cuff to extremely high pressures in people with normal or low blood pressure. When you detect an auscultatory gap, record the systolic and diastolic pressures as usual, and note the magnitude and range of the auscultatory gap, like 196/90, auscultatory gap from 184 to 150. The table summarizes potential sources of error in blood pressure measurement. Purpose of obtaining blood pressure. 1. Evaluate the client's hemodynamic status by obtaining information about cardiac output, blood volume, peripheral vascular resistance, and arterial wall elasticity. 2. Obtain baseline measurement of blood pressure. 3. Monitor the hemodynamic response to various therapies or disease conditions. And 4. Screen for hypertension. One. Assess blood pressure on initial client examination. 2. Identify factors that may alter blood pressure: medications, exercise, age, emotional conditions, smoking, postural changes. 3. Assess best site for obtaining blood pressure. 4. Review previous blood pressure readings, if available. 5. Consider any factors that limit site selection, like mastectomy, dialysis access, PICC Klein. Obtaining blood pressure. 1. Wash hands, identify client, explain procedure to client, assist client to a comfortable position with forearms supported at heart level and palm up. Rationale: variations in blood pressure can occur with client in different positions. Blood pressure increases when the arm is below heart level and decreases when above heart level. Diastolic blood pressure may increase 10% if arm is unsupported, secondary to isometric muscle contraction, used to support arm. 2. Expose the upper arm completely. Rationale: accurate placement of cuff and stethoscope requires complete exposure of upper arm. 3. Wrap deflated cuff snugly around upper arm with center of bladder over brachial artery. Lower border of cuff should be about 2 cm above antecubital space, nearer the antecubital space on an infant. Rationale: placing bladder directly over brachial artery ensures proper compression of artery during cuff inflation. Loose or uneven application can result in falsely high readings. 4. Palpate brachial or radial artery with fingertips. Close valve on pressure bulb and inflate cuff until pulse disappears. Inflate cuff 30 mm Hg higher. Slowly release valve and note reading when pulse reappears. Rationale: identify approximate systolic blood pressure reading to prevent underestimating systolic blood pressure should client have an auscultatory gap. Note: some researchers state that this two-step method may result in significantly lower diastolic readings, requires more time, and may cause the client longer periods of stress. It is most important to use the two-step method during the initial screening to detect the presence of an auscultatory gap. 5. Fully deflate cuff, and wait 1 to 2 minutes. Rationale: a waiting period prevents falsely high readings by allowing blood trapped in the vein to be recirculated. 6. Place stethoscope earpiece in ears. Repulpate the brachial artery and place stethoscope bell or diaphragm over site. Rationale: blood pressure is a low-frequency sound and is best heard with the stethoscope bell, but the diaphragm is widely used because it is easily placed and more generally available. 7. Close bulb valve by turning clockwise. Inflate cuff to 30 mm Hg above reading where brachial pulse disappeared. Rationale: ensures accurate assessment of systolic blood pressure. 8. Slowly release valve so pressure drops about 2 to 3 mm Hg per second. Rationale: inaccurate measurements may occur if deflation rate is too fast or too slow. 9. Identify manometer reading when first clear Korotkov sound is heard. Rationale: indicates systolic pressure reading. 10. Continue to deflate, and note reading when sound muffles or dampens, 4th Korotkov, and when it disappears, 5th Korotkov. Rationale: American Heart Association recommends using the 5th Korotkov sound as diastolic pressure in adults, 4th Korotkov in children. In adults, if 4th and 5th Korotkov are 10 mm Hg or greater apart, note all 3 readings. 11. Deflate cuff completely and remove from client's arm. 12. Record blood pressure. Record systolic like 130, and diastolic, like 80, in the form 130/80. Abbreviate RA or LA to indicate right or left arm measurement. Rationale: maintains legal record and communicates with health team members. Pain is a highly unpleasant and very personal sensation that cannot be shared with others. Accurate pain assessment is essential for effective pain management. Many health facilities are making pain assessment the 5th vital sign. Because pain is subjective and experienced uniquely by each individual, nurses need to assess all factors affecting the pain experience: physiologic, psychologic, behavioral, emotional and socio-cultural. The single most important indicator of the existence of pain and indicator of pain is the client's report of pain. The use of pain intensity scales is an easy and reliable method of determining the client's pain intensity. Such scale provide consistency for nurses to communicate with the client and other healthcare providers. Most scales use 0 to 10 range, with 0 indicating no pain, and the highest number indication the worst pain possible for our individual. However, not all clients can understand or relate to numerical pain intensity scales. These include children who are unable to communicate discomfort verbally, elderly clients with impairment in cognition or communication. FACE's rating scale may be easier to use. The FACE scale includes number scale in relation to each expression so that the pain intensity is documented. Pain assessment consists of two major components: 1. A pain history to obtain facts from the client, and 2. Direct observation of behavioral and physiologic responses of the client. The goal of the assessment is to gain an objective understanding of a subjective experience. The table shows a helpful mnemonics to make a complete pain assessment. A pulse oximeter is a non-invasive device that measures a client's arterial blood oxygenation by means of a sensor attached to the client's finger, as shown in the image, or toe, nose, earlobe or forehead, or around the hand or foot of a neonate. The pulse oximeter can detect hypoxemia before clinical signs and symptoms such as dusky skin color and dusky nail beds color develop. Measuring oxygen saturation. Purposes: 1. To measure the arterial blood oxygenation. 2. To detect the presence of hypoxemia before visible signs develop. Assess for the following. 1. The best location for a pulse oximeter sensor based on the client's age and physical condition. 2. The client's overall condition including risk factor for development of hypoxemia like respiratory or cardiac disease. And hemoglobin level. 3. Vital signs, skin and nail bed color and tissue perfusion of extremities as baseline data. And 4. Adhesive allergy. Measuring oxygen saturation. First, check that the oximeter equipment is functioning normally. Explain to the client what you are going to do, why it is necessary, and how he can cooperate. Observe appropriate infection control. Provide for client privacy. Choose a sensor appropriate fit the client's weight, size and desired location. If the client is allergic to adhesive, use a clip or sensor without adhesive. Prepare the site. Clean the site with an alcohol wipe before applying sensor. It may be necessary to remove a client's nail polish. Apply the sensor or the pulse oximeter. Make sure the LED and photodetector is aligned. Set and turn on the alarm. Check the preset limits for high and low oxygen saturation. Ensure client safety. Inspect or move or change location of an adhesive toe or finger sensor. Inspect the site for irritation from adhesive sensor. Ensure the accuracy of measurement. Minimize motion artifacts by using adhesive sensor or immobilize the client's monitoring sites. Last, document the oxygen saturation on the appropriate record at designated intervals. In summary, vital signs reflect changes in the body function that otherwise might not be observed. Body temperature is the balance between heat produced by the body and heat lost from the body. Common types of fever: intermittent, remittent, relapsing, and constant. Clinical signs of fever vary during onset, course and abatement. Body temperature can be measured orally, tympanically, rectally or by axilla. The nurse selects the most appropriate site according to age and condition. Pulse rate and volume reflect the stroke volume output, compliance of client's arteries, and the adequacy of blood flow. Normally, a peripheral pulse reflects the client's heartbeat, but it may differ from the heartbeat in clients with certain cardiovascular disease. In these instances, the nurse takes an apical pulse and compares it to the peripheral pulse. Respirations are normally quiet, effortless, and automatic and are assessed by observing respiratory rate, depth, rhythm, quality and effectiveness. Blood pressure reflects cardiac output, peripheral vascular resistance, blood volume and viscosity. A blood pressure cuff too large or too small or too tight too loose will give false readings. During blood pressure measurement, the artery must be held at heart level. A normal oxygen saturation is 95% to 100%. Pulse oximeter sensor may be placed on fingers, hand, foot or nose. The tasks involved in measuring vital signs are simple and easy to learn, but interpreting the measurements and incorporating them into ongoing care and assessment require knowledge, problem-solving skills, critical thinking, and experience. Although measuring vital signs are usually part of routine care, they provide valuable information and their evaluation should not be taken lightly.